Hi, I'm Matt Collins, and today I'm going to be talking to you about patient preparation for drug-facilitated intubation. The first step and most important step in drug-facilitated intubation is patient positioning. I've got my patients positioned supine and in the middle of the room as best I can, and this is what you should aim for whilst out on the road, so you can have complete 360-degree access to the patient. I'll position the patient with a towel underneath his head to optimise the best position for intubation. I'm trying to get the ear canal parallel in line with the sternal notch to help with this. Further with patient positioning is the equipment that we use for intubation of the patient. Our monitor is a major aspect of intubation, and so monitor access for all people involved in intubation is paramount. So positioning it to the left there so that I can access it, the patient given the drugs who will be on my right over here can access it also, and then my airway assistant also. Attached to my monitor, I've got my blood pressure cuff attached to the patient, and then I've got my monitoring dots, or 4 leads, and then I've got my SpO2 as well, which if you're able to have it on the opposite hand to your blood pressure cuff. Next step for drug-facilitated intubation is the pre-oxygenation of the patient. I've got here set up my bag valve mask with my mask attached to my licorice stick. I've got a bacterial filter, then an end tidal with a PEEP valve set at 5 centimetres of water. And then the end tidal here I can just attach into my monitor over there. My bag valve mask is attached to its own separate oxygen bag here, which is full, and made sure that it was full prior to intubation. And then also I've got some nasal cannulas on the patient as well, which is also hooked up to its own oxygen supply with adequate supply inside of it. I run my nasal cannula at 15 litres per minute to allow for apneic pre-oxygenation, and then also with my oxygen mask ensure that my reservoir bag is full, which would be full with the oxygen running through it. For pre-oxygenation, I use my BVM, and the ultimate BVM technique would be for 2-person technique, with 1 person holding the jaw underneath the mandible with their 3 fingers, and then holding the top of the mask like so to ensure adequate seal. Or if you're able to get good enough seal, you could do 1 person. The best option would be for 2 people so that you have a good seal, because if you don't have a good seal, because nitrogen can get in with a patient taking a breath, and the aim of pre-oxygenation is to denitrogen the patient and fill with oxygen. With my nasal cannulas, which are dialed up to 15 litres per minute, allows for apneic oxygenation. What apneic oxygenation allows is for a prolongation of desatting of the patient once you've given the drugs and you're trying to intubate them without them taking any ventilations. With good pre-oxygenation and good apneic oxygenation, it can prolong your apnea period for intubation to up to 8 minutes. Now, to perform the actual skill of pre-oxygenating the patient, I'll put them in the optimum position with the head back, head tilt, and in the sniffing position. I've clamped my 2 fingers around the top of the mask to ensure adequate seal, and I've got my 3 little fingers around the edge of the mandible here, lifting the jaw up into the mask. I've got my oxygen flowing at 15 litres per minute minimum to a full reservoir bag, and I'm able to positively pressure ventilate the patient, ensuring adequate pre-oxygenation for the patient. I do this for at least 3 to 5 minutes leading up to drug-facilitated intubation. So for my advanced airway setup for intubation, I've got my two laryngoscope blades here, the size 3 and 4. I've also got my Video McGrath Mac blade here for anticipated difficult intubation, or in the case of a trauma patient, if you've got a spinal patient that you can't be lifting the head up too much, this allows for that view. And if we go over here, I've got my suction unit attached to my catheter, which I have sitting underneath the patient here, ready to go. And I have all my equipment. I have my size 7 tube with the introducer inside it already, and then I've got one size down, size 6, with an introducer already inside of it. I've got my 10mm syringe. My 10mm syringe for when I've intubated the patient, I can blow up the cuff. I have my bougie here for a difficult airway, or if I just want to use it for first intubation attempt. I've got my easy cap, which isn't opened, because once it's opened and it's sitting there, you can't use it for end tidal detection. I've got my OPA airway for my blight block. I've got some failed intubation equipment. I've got my iGel, which is the appropriate size for my patient here. I've got the quick track here, and I've got McGill's forceps if needed. And then I've got my nasogastric tube with my nasogastric bag and my syringe tip to aspirate to check that I'm in the stomach. And I've also got my stethoscope here to listen to breath sounds once I've intubated, as one of the checks for placement in the trachea of the tube. And to secure my tube, I've got some pre-cut tape here to tie the tube into place to make sure it's secure. Whilst I'm pre-oxygenating the patient, my mica partner is going to be drying up our drugs for intubation. He's going to draw up some 600 mics in 1 ml of atropine for bradycardia at any stage through the RSI. He's going to draw up 200 milligrams in 20 mils of ketamine. For this patient, they're indicated for ketamine induction. For other patients, they can be fentanyl midaz induction. So he's going to get a dose of 1.5 milligrams per kilo to a max of 200. I've got some succinylmethonium drawn up here as well. They're going to get 1.5 milligrams per kilo to a max of 150 milligrams to closest 25 milligrams. I've got my 1 in 10,000 adrenaline drawn up to 100 mics in 1 mil, which is labelled 100 mics on the end, and then I've coloured in the syringe. Then also I've drawn up 10 mics per mil from my 1 in 10,000 ampule as well. Set aside, I've got my pancuronium for confirmation of intubation with end tidal, and that'll be 8 milligrams in 4 mils. Here I've got my morph-midaz post-intubation sedation. I've got 30 milligrams of morph and 30 milligrams of midaz mixed up to 30 mils of normal saline. And I've got an adrenaline infusion, 3 milligrams of adrenaline mixed up to 50 mils of normal saline for post-intubation perfusion if required. Thank you for watching my video on patient preparation.